Thanks, everyone. Thanks, Daniel. Thanks to all the participants so far and the speaker. And it's a great pleasure and honor for me to chair this session about neglected tropical diseases. Together with Alexandra Cruz, Thomas Jensen, and with the support of Jaap Carsten and Nicola Morson, we have tried our best to focus on, to arrange this session and focus on the term neglect. We know that often the neglect can start in front of the human being we are treating in our context, especially if we don't take them with an holistic approach. And then it can spread to the knowledge of the diseases we encounter in our daily practice. It can spread to the context where we work if we don't pay attention to the epidemiology and to the climate change event that have been discussed so far in these days and in these sessions. So therefore, we decided to focus on some of the diseases and then have a debate around them. We know it can be a quite complex topic, very based and diverse. So it was difficult for us to try to focus on some of them, but we tried our best. And we decided to start where often everything begins. I mean, at the bedside of the patient. And in order to do so, we would like to present you a clinical case. It would be a short clinical case, but we will need your help to try to solve it. So please come with me to do the warrant. We need to imagine to be in the MSF-IPD clinic in the north of Burkina Faso. It's 9 a.m. in the morning, and we have started the war round. So we noticed that a boy called Musa has just been admitted overnight. He's 11-year-old, and he sits in the bed close to a lady who is actually his grandmother. As good pediatricians, we approach first to him saying, "Good morning, Musa. What happened to you?" And to the lady sit close to him, to his grandmother. The lady looks very worried. She is saying that he has been hot over the past 3 days, complaining of itching, coughing a bit. He looks very tired. His legs are hurting, so he's not able to walk properly. So we start to investigate a bit with the lady what really happened during these days. And we ask her if he got any drugs. She said that she took him to a health post a few days before. They took some bloods, but the test was negative. Therefore, they sent him home, where she gave him some herbal remedies, as they do for people who have some diarrhea, because of course he had also some diarrhea. And she didn't forget to give him the malaria tablet, because every Sunday he's taking his malaria tablet. We are asking also to the lady if they have some medical problem in the family, and the lady says, "Well, my husband died of TB. We all have sickle cell disease in the family, but Musa and his mother have been tested and resulted heterozygous." At his physical examination, it does not look very sick. He's in discomfort for pruritus. He still has some fever. The vital signs are quite normal, as you can see, but he has this sparse urticaria rash all over the body. He is working with some difficulties because he has pain in the legs. And at the chest examination, he has some wheeze all over the chest with mild hepatosplenomegaly and cervical lymphadenopathy, but otherwise no abnormalities have been noticed. So during the war round, we discovered that already the night team performed some routine investigation at his arrival. His hemoglobin was 13 gram deciliter. He has elevated white cell with clear eosinophilia. They tried to perform the malaria antigen test, but he was in rupture. So they did a tick drop, which showed negative result for malaria parasite, but as you can see, it can erase this little funny purple thing that the lab technician interpreted like as a debris. In the clinical note, we found also that they already performed some investigation, like urine exam, which resulted positive for blood with a negative microscopy, and a chest X-ray, which shows some bilateral infiltration, probably more highlighted on the right side. as you can see from the picture. So if we can have a look at the usual suspect that we can raise from this context, we can think about a malaria, we can think about a manifestation of sickle cell disease, albeit in an heterozygous patient. We can think about local remedies of side effects that we know are often affecting the population we see. We can think about community-acquired pneumonia, some viral infection, of course, COVID-19. But what could be our next step? And now I would like to launch a polling question to all of you. So if you go on your right-hand side to the poll tab, you can see all the answers, and please scroll them down until you find the right one and submit it. We will give you approximately 30 seconds to vote. Should we do an ML test, considering that the hemoglobin is 13 gram deciliter? Should we recheck the tick drop ourselves with another experienced lab technician? Should we start anti-malaria treatment, maybe IV this time? Should we interview the boy for more details? Should we start treatment for community-acquired pneumonia and keep a typical NTB always at the back of our mind? Or should we post the case on telemedicine for additional support? So I let you vote. It can be very tricky given the information we have received. And I can see the majority of you think, well, it's still running the poll, but there are mixed answering coming out. I know it's not very easy, but we will see. We will discuss the answer later. I would like now to continue the case, if you agree. Of course, all answer can have a partial truth in it. So I think now to discover better what happened in the case, we need to ask more questions. Actually, to the boy. Actually, we discovered that the nurse who admits the patient had some very precious information. The nurse already talked with Moussa, and he discovered that he lives in France. And this was the first time he visited the grandmother. He cannot speak the language, but he really understands very well all the friends he has there. And has been always well, apart from COVID-19, just before arriving over there, 4 weeks before. In the plane, he did not wear a mask. From a feeding perspective, he does not like milk and vegetable. He loves goats, but the grandma has only a dog around the house. He does not spend much time inside the house of the grandmother because he loves to play outside with his friends, especially going to play in the river, in the water. Of course, always wearing sandals. At this point, what do you suspect now, having received this precious information that the nurse already collects from Moussa? And again, I would like to launch a second polling question, again with the 30 seconds to vote on your right-hand side poll tab. Should we suspect malaria, despite the tick drop slide we have seen before? Should we suspect a community-acquired pneumonia? Should we think about a reaction to drugs, local herbs that the grandma gave him? Should we still stick up to viral respiratory infection, considering the diarrhea and respiratory symptoms he have? Should we think about hematuria from post-streptococcal glomerulonephritis, or none of the above? Again, difficult to know without knowing some information, right? But therefore, it's important to work in a team, I think. And always having the possibility to share our doubts. So I can start to see that the majority of you voted none of the above. Great. I don't think malaria is an option. The tick drop was negative. Some of you voted local herbs, drug reaction, which is very likely to happen in the context we work. But for example, hematuria from a post-streptococcal glomerulonephritis was not really an option, as he didn't have any sore throat in the past or other streptococcal infection. So let's have a look to what he has. given the country of origin and the schistosomiasis endemicity in Burkina Faso, given the subacute clinical picture that most show, including the skin rash that is very important to consider, the serum eosinophilia, the urine dipstick, and the fact that he told us he play in the water, the diagnosis of early stage of schistosomiasis was made, and it's called Katayama fever. Therefore, a treatment, initial prednisolone was started only after with praziquantel. Yeah. So thank you for your help to solve the case. The take-home messages that we would like to raise are that not all fever are malaria. We need to remember this, especially if symptoms are not improving and the history does not fit with the scenario. The history is fundamental in order not to neglect the patient and the diseases. So we need to take the information we will receive from children and their family as very important. In case we are not able to solve, we have doubts, please remember that we are a team. We have a team close to us, including doctors, nurses, everyone, to address questions. And for complex cases, there is telemedicine. That is a great support for the field. There are international resource pipelines where entities and pediatric working groups are working on the guidelines to develop a fever algorithm beyond the usual suspect that we can raise in case of in front of complex clinical cases. So we will be soon ready. But also we need to remember that we need to know the area we are working. And like CDC, WHO, they have important tools to know the epidemiology of the places we work. We need to remember that Katayama fever occurs mainly in immune-naive people. So think about it in travelers, IDP, migrants, but also in immune-naive places. We need to take in mind into account that the climate changes are affecting the area we are working. So we need to suspect diseases that were not previously seen. And it's a systemic hypersensitivity reaction. So therefore steroids first, but this is just related to this condition. So again, thank you for helping to solve the case. This is just to set the scene to the complex topic of neglected tropical diseases.